over-the-scope, clip-assisted method for resection of full-thickness submucosal lesions of the gastrointestinal tract. Since its introduction to clinical practice a few years ago, the novel endoscopic closure device called the over-the-scope clip, OTSC system, of Endoscopy, Tübingen, Germany, has increased the ability of the therapeutic endoscopist to close gastrointestinal luminal defects such as fistulas, leaks, and perforations, and to treat gastrointestinal bleeding. This clipping device, which is made of nitinol, is deployed after suctioning tissue into the distant transparent cap. In animal experiments, Von Renteln et al. Demonstrated that the tissue entrapped above the closed clip could be resected safely. The authors then reported on the feasibility of full-thickness resection of submucosal gastric tumors. The aim of the current study was to evaluate the efficacy and safety of the OTC for the resection of luminal gastrointestinal tumors in humans. Background and study aims. The over-the-scope clip, OTSC, is deployed after suctioning tissue into the cap. The tissue may then be resected endoscopically. The aim of this study was to evaluate the efficacy and safety of the OTSC for the endoscopic resection of gastrointestinal tumors. Patients and methods. This was a retrospective, observational cohort study of patients undergoing endoscopic resection of the submucosal lesions. Results. 8 patients underwent endoscopic resection of the neuroendocrine tumors, NETs, of the duodenum, N equals 4, rectum, N equals 1, or stomach, N equals 2, or granular cell tumor, GCT, of the esophagus, N equals 1. The mean size of the lesions was 13.4 millimeters, range 9 to 20 millimeters. Application of the clip was successful in all patients. A successful endoscopic resection was accomplished in all. A complete resection, R0, was accomplished in 7-8 patients, 87.5%. A full-thickness resection was achieved in 2/8, 25%. One in a patient with a gastric NET and the other in a patient with GCT of the esophagus. There were no complications. Conclusions. The authors believe that the OTSC may be a useful technique to remove lesions that are less than 20 millimeters in size and lie above the muscle layer. Thus, performing endoscopic ultrasound to clearly define the size and location of the lesion is mandatory. We recommend that only lesions above the muscularis propria should be targeted. In addition, when planning an endoscopic resection, an organ-specific approach is indicated, as the elasticity and thickness of the digestive wall varies within the gastrointestinal tract. The amount of tissue suctioned into the cap will vary between the esophagus, stomach, small bowel, and colon. Furthermore, careful apposition of the cap against the wall is mandatory, as suctioning of non-lesional mucosa and gastrointestinal wall may result in lumen occlusion. Mönkemüller et al. Have developed several techniques to keep the lumen visible during the deployment of the OTSC, including the placement of a guide wire, nasogastric tube, or nasogastric tube with guide wire into the gastrointestinal lumen, parallel to the endoscope. Thus, the lumen is always visible and occlusion is prevented once the clip is applied. This case suggests that the OTSC system may be a valuable tool for the resection of the submucosal lesions, but further prospective and randomized studies are necessary to assess the indications and outcome.